So what is pharmacodynamics? It is what do you call? It is the action of the drug on the patient's body. What is pharmacokinetics? It is action of body on the drug. Right? What is bioavailability? Bioavailability is basically it refers to the rate and extent of absorption of a drug from the dosage form that it is given and how it reaches the blood circulation and how much of the concentration of the drug is available in the blood to act on the respective target organ. What is pharmacogenetics? It is the study of genetic basis for the variability in drug response. What is pharmacogenomics, which is very important nowadays in oncology? Pharmacogenomics. It is basically the genetic information from the patient. It is used to guide the choice of drug. The genetic information is taken from the patient and that helps in finding out what drug works well for this particular patient. This is currently called as the gene-targeted therapy. This is the basis behind the gene-targeted therapy in oncology as of now. Then the other terms to know is clearance. What is clearance? Clearance is the volume of the plasma that gets filtered of the drug in that particular unit time. That is clearance. Then volume of distribution of a particular drug is amount of drug divided by the plasma amount of drug given divided by the plasma concentration of that particular drug. This is volume of distribution. Then what is half-life? Half-life is the time taken by the drug to reduce to its concentration by 50%. Like half of it will go off. That is half-life. What is zero-order kinetics? This you should tell me the answer. Zero-order kinetics and first-order kinetics. Zero-order kinetics, what is it? Anyone? Zero-order kinetics and first-order kinetics. Come on, what is zero-order?
Drug eliminated in our time.
Yes. Constant amount of drug will come out in zero-order kinetics. In first-order kinetics, what will happen?
Constant fraction of drug.
Exactly. Constant fraction of a drug will come. Say, for example, if there is a box that is filled with particular agent, if its constant amount means, say 10 ml is only removed from this box. So what will happen? 10 ml will only be removed. And the next time it's metabolized, another 10 ml will be removed. So it will go like this. Right? But in case of first order kinetics, what happens? Here, constant fraction. Suppose there is a box of this sort. Is there? Constant fraction, say 50% is removed at one particular time means this 50% will be half of it. It will become like this. And next again 50% will be removed. So in this 50% will be only this part. So when the constant fraction gets removed out of the system, that means that it is a faster metabolism and drug goes out of the body at a very faster rate than expected. Examples of zero-order kinetics, which is what is more important. Most of the drugs are first-order kinetics. Zero-order kinetics is more important because there are few important drugs. Any one example?
Aspirin.
First, alcohol. I agree. Aspirin is also alcohol. When someone brings in alcohol, it takes a lot of time for the concentration to come down. So, aspirin, alcohol, warfarin, phenytoin, theophylline, and tolbutamide. These are few examples of first order kinetics. That is very important for you to know about the first order kinetics. Next, so these are the basics of pharmacology. That's coming to ANS. In ANS, of course, you have to know you have the sympathetic and the parasympathetic system. Sympathetic means what and parasympathetic means what? You tell me. These are all first year subjects. Parasympathetic, what are the cranial? It's actually what? Cranio? Craniosacral, right? Craniosacral outflow will be parasympathetic, whereas this will be thoracolumbar. What are the cranial nerves that is involved in the parasympathetic supply? Come on, what are the cranial nerves involved in the parasympathetic supply? What? Fast.
Vagus.
Okay, then what else? Come on, guys. Is physiology revision over for you people?
3, 7, 9, and 10.
3, 7, 9, and 10. Okay, these are the cranial nerves that are involved in the parasympathetic supply. Usually, the sympathetic from the spinal cord, there will be preganglionic fiber. It go and synapse in the so-called sympathetic chain that runs parallel to the spinal cord, and from there gives the postganglionic fiber, and this ganglionic fiber in turn goes and supplies the respective organs, right? So I will say in this, the length of the preganglionic fiber will be short and postganglionic fiber will be long. What happens in the parasympathetic system? In the parasympathetic system, the ganglion in which it synapses is almost near to that particular receptor organ. So preganglionic will be long and postganglionic will be short postganglionic fibers. Right? So this is what is regarding the basics of sympathetic and parasympathetic fibers. Then you have to know something regarding the receptors. How many receptors? What are those receptors? Tell me. Tell me. I'm not going to tell you all these things. What are the receptors in the sympathetic and parasympathetic system? Yes. Alpha, beta, nicotinic receptors, and muscarinic receptors, right? Come on. Okay, anyway. Alpha means alpha, you have two, alpha 1 and alpha 2. Where is alpha 1 present? It is usually present in the smooth muscle cells as well as in the glands. Alpha 2 is basically an autoreceptor. And hence, since it is an autoreceptor, obviously it will be present in the presynaptic nerve terminals and postsynaptic nerve terminals. Beta receptors, beta 1 will be present in where?
Heart.
Heart. Correct. Beta 1 will be in the heart as well as in the GJ cells of the kidney. Beta 2 mainly in the lungs, blood vessels, GIT, bladder, uterus, skeletal muscles. All right. Then beta 3 will be seen in beta 3 will be seen in how much? Mostly in the adipose tissue. Beta 3 will be seen in the adipose tissue. How about the nicotinic receptors? In nicotinic, you have two. NN is the nicotinic neuron receptors that is mostly present in the ganglia and adrenal medulla. Whereas nicotinic NM will be in the neuromuscular junction. Right? Then coming to the muscular receptors, muscarinic receptors. M1 is present here. The CNS, autonomic ganglia, then in the gastric glands. M2 will be present in the heart. M3 will be present in the smooth muscle cells, glands, and the endothelium. All right. So this is what is regarding the receptors. Now coming to the drugs which are acting at the level of these receptors. If it's an endogenous receptor, mean the direct, you call it whenever the particular chemical acts at this ganglion and it produces a positive effect, it is called as the sympathomimetics. Right? Sympathomimetics. The one which directly acts at these receptors are directly acting sympathomimetics. This direct sympathomimetics, it can be either given exogenously or it can be produced endogenously inside the body. What are the endogenous sympathomimetics that you know of? Dopamine, adrenaline, and noradrenaline. Right? What are the uses of this drug? Of course, all are used for management of shock. Right? And this adrenaline is mainly used for the management of cardiac arrest. Noradrenaline is used in the management of hypotension or a congestive heart failure. Dopamine is also used in the treatment of hypotension and congestive heart failure. How about the exogenous directly acting sympathomimetics? Example, someone? Some example? Tell me. I'm just using this time to fill up the color. The butamine. This is an the butamine is an agent. This is mainly used for increasing the cardiac pumping effect in congestive heart cardiac failure. Then phenoldiazepine. Phenoldiazepine is used in the treatment of hypertensive urgencies. Isoprenaline. Isoprenaline is mainly used in heart blocks. Right? This is what is regarding the directly acting symptomatics, and all these things are called as the catecholamines. There are other drugs which are non-catecholamines, but still they act at individual receptors which are used in the treatment of the particular diseases. One such drugs are like alpha 1 agonists. Example, first example is phenylephrine. Phenylephrine is directly acts at the alpha receptors, thereby causing vasoconstriction. So this vasoconstriction property of phenylephrine is used in case of spinal induced hypotension. In case of a spinal, after giving a spinal anesthesia, you have hypotension, right? If that patient has a tachycardia, if the heart rate, the problem with this phenylephrine is, as this alpha 1 is constricted in the vessels, this sends signal to the brain, and thereby the brain gives a reflex bradycardia. So problem with this phenylephrine is there will be a reflex bradycardia, and hence spinal hypotension plus tachycardia. Only in case when the tachycardia is there, you should give this phenylephrine. If the tachycardia is not there, you rather give ephedrine, which acts at the alpha as well as the beta 1 receptors, so that heart rate is not lowered while giving that particular drug, ephedrine. So this is this first phenylephrine. Second thing, the other use of phenylephrine, it is used in producing mydriasis. It causes mydriasis and helps in the diagnosis of this glaucoma and all the things. Then the other alpha 1 agonist that you know of could be mephentamine. This is also used in the treatment of shock or like spinal hypotension, all you can use. Then the other agent that is xylometazoline, oxymetazoline, optimetazoline, nafzoline. These are all used as nasal decongestants. Right? The other alpha 1 agonist which is used is the clonidine. I will say clonidine is not exactly an alpha 1 agonist, it is rather an alpha 2 agonist. Because alpha 1 is to alpha 2, the ratio will be 1 is to 220. It will act more on the alpha 2 level. So since it acts at the alpha 2 level, this will also have a high chances of causing bradycardia. It is used in the treatment of hypertension. It will hypertension. I should not scribble this part because you might read it wrong. Hypertension. There are chances of reflex bradycardia to happen after giving clonidine. Then clonidine other uses, it is also used in the treatment of, it is used in as an adjuvant in anesthesia. Adjuvant in spinal anesthesia as well as in the general anesthesia. In general anesthesia, it is used for a hypotensive anesthesia. In spinal, it is used in the prolongation of the act of the spinal anesthesia. Then it is used in attention deficit hyperkinetic disorder treatment. And sometimes it is used in patients with diarrhea and diabetes with an autonomic neuropathy. Okay. It is also used in the treatment of alcohol withdrawal. Right? Then coming to the other alpha agonist, dexmedetomidine. Dexmedetomidine, this is also an alpha 2 agonist. Alpha 1 is to alpha 2 ratio will be around 1 is to 1200 roughly. So it acts more at the alpha 2 level. And this will cause, of course, it is hypotensive anesthesia. And it is used as a sedative agent. It is used as a sedative agent. Then tizanidine. Tizanidine is used as a muscle relaxant. Right? Then coming to beta 1 agonist, not much beta 1 agonist. I told you This ephedrine. This is the one which acts at both alpha and the beta level. So it causes hypertension, increase in the BP as well as increase in the heart rate. Hence used in treating the patients with the bradycardia and hypotension. Then beta 2 agonist. You have short acting and long acting ones. Short acting bronchodilators or short acting beta agonists are used in the treatment of bronchial asthma, of course, salbutamol. Long acting example, it is salmeterol, right? Then ritodrine or isosipren. These both are used in the treatment of tocolytics. In premature uterine contractions, these are used as a tocolytic agent. Then beta 3 agonist, mirabegron. Is used in the treatment of overactive bladder. Treats overactive bladder. Okay. Then coming to the D1 receptors, dopamine receptors. D1 receptor agonist example. You say some answer from that side only, then I will also feel. Otherwise, I will feel sleepy. D1 agonist example. Phenol-dopam is a D1 agonist and it is used in the treatment of hypertension. D2 agonist, it is bromocriptine. Am I audible to you people?
Yes, ma'am. Yes,
okay. Ma'am. Bromocriptine, it is used in the treatment of what? Bromocriptine, it is used in the treatment of prolactinemia. Very important. It is used in the treatment of prolactinemia and it is also used for treating the overactive bladder. Sorry, not overactive, P for P. This Parkinsonism. I remember it as BP and another P. Too much of increased BP, so BPP. So bromocriptine, prolactinemia and Parkinson's syndrome. So this is what is regarding the agonist. Then coming to the blockers, alpha blockers can be non-selective, which blocks both alpha 1 and alpha 2, both when we block. Example, phenoxybenzamine, phentolamine. Its uses, any idea what are the uses? It is used to the treatment of pheochromocytoma. Pheochromocytomas is a condition where you have increased level of circulating catecholamines in the body. Then alpha 1 selective blocker. Example, resorcin, doxazosin, terazosin, tamsulosin. It is used for the treatment of what? Come on, this answer, you should know this answer. Answer me, what it is used in the treatment of? Urinary retention in BPH. It is used to treat urinary retention in BPH. Okay, then selective alpha 2 blockers. The one thing which you have to know is yohimbine. That is enough for you. This yohimbine is used in the treatment of erectile dysfunction. It is used in the treatment of erectile dysfunction. So this is what is regarding the alpha blockers. Beta blockers, it is a big list of beta blockers, which I'm not going to say. You go read the first generation and second generation beta blockers. I will tell you the important MCQ points in beta blockers. The beta blocker with the alpha blocking activity, like beta blocker along with an alpha 1 blocking property is seen with labetalol, right? Hence, there won't be any increase in the heart rate when you treat the patient with labetalol. The other drug is carvedilol. Carvedilol, it causes a beta blocker, alpha 1 blocking effect, also calcium channel blockers. Then, the one with an beta blocking effect, then alpha 1 blocking effect, but beta 2 and beta 3 agonistic effect. What is the drug? The drug is bucindolol, right? Then beta 1 blocker is a selective beta 1 blocker along with beta 2 agonistic activity. This drug is celiprolol. Beta 1 selective blocker would be nebivolol, right? So this is what is regarding the beta blockers that is most commonly asked in MCQ. The other MCQ that can be possibly asked in beta blockers is the beta blocker having membrane stabilizing activity. Membrane stabilizing activity. What is the beta blockers? Answer is propranolol, metoprolol, labetalol, acebutolol, pindolol. You can remember it as PM lab is in AP, Andhra Pradesh. If you can remember it like this. If you have any other mnemonic, you can remember like this. The other thing which you have to know is the cardioselective beta blockers. Cardioselective beta blockers, it is mainly seen, the main drugs are betoxolol, bisoprolol, atenolol, esmolol, acebutolol, metoprolol, celiprolol. These are the cardioselective beta blockers. So this is what is regarding the sympathetic system. Then coming to the parasympathetic drugs. Parasympathetomimetics. Parasympathetomimetics. In that you have many drugs like directly acting drugs. Direct acting like this bethanacol. It is used in the treatment of urinary constriction. It relaxes the urinary bladder. Then methacholine. Methacholine is used to diagnose the bronchial hyperactivity. Pilocarpine. Where is it used? Pilocarpine. Answer. Pilocarpine is used to treat glaucoma. It is used. It is a meiosis. Causes meiosis, right? So it is used to not glaucoma. Then indirect acting. Physostigmine. Where is it used?
Myasthenia gravis.
Yes, it is used in the treatment of myasthenia gravis. Of course, it is also used in the treatment of glaucoma, myasthenia gravis. Then it is also used in the as an antidote of atropine poisoning. Then neostigmine. Neostigmine, where is all used? It is used as a muscle relaxant reversal agent of muscle relaxants. It is also used for myasthenia gravis. It is used for this post-op paralytic ileus. Post-op paralytic ileus. They also use the treatment of cobra bite. Right? So this is the one. Then what else? Hydrophonium. Where is it used? Hydrophonium. It is used in the diagnosis of myasthenia gravis. It is used in the diagnosis of myasthenia gravis. Then there are few drugs which are parasympathomimetics, and it is irreversible. Once it attaches to the receptor, you cannot reverse it. If it's irreversible, means definitely it will be a problem. Example is organophosphates, and hence organophosphate poisoning is very difficult to treat. Organophosphates and carbamates are parasympathomimetic agents that is misused, ideally which is used for this insecticide has been illegally used as a poison, and they consume it, and the treatment would be parasympatholytic. That will be the treatment of choice. So coming to the parasympatholytics, depending on the receptors, there are few drugs which acts. If you take the receptor spectrum, parasympathetic receptors means M1, M2, M3, right? So M1 receptor blocker would be pyranzipine. Pyranzipine is used in the treatment of peptic ulcer disease. Second, M2 blockers would be tryptamine. It is used in the for increasing the cardiac contractility. M3 blocker will be darifenazine. This darifenazine is used to treat overactive bladder. And irritable bowel syndrome or irritable bowel disease. Then non-selective, that is, it is acts on all the receptors, M1, M2, and M3 blocker. That is nothing but the atropine. Atropine is used in the treatment of course, bradycardia. Then the other non-selective one is the hyoscine. Hyoscine is it is used in the treatment of what all? Hyoscine is in the treatment of motion sickness and spasm, antispasmodics. It is an antispasmodic, right? Then the other drugs important in the system could be hemicolinium, which reduces the choline uptake. It was earlier used, but nowadays not used. Vesamicol is not all used. The one which is used is the Botox, where there is a botulinum toxin which decreases the acetylcholine released from that particular receptor. And this is used in many areas where they want to relieve the spasm, like in strabismus, labirospasm, cervical dystonia. Right? This will be the pattern how the sympathetics and parasympathetics act. Yes, that's all regarding the ANS. Then going to the CVS. In CVS, you have to know about the antiarrhythmics. What is the name of the classification of antiarrhythmic agents? Hmm? Vaughan Williams classification of antiarrhythmic agents. I have read this many times, but still, even now, I make a mistake in this. I don't know. I'm not able to memorize this chart alone. I find it every time, even for my examination, I had the difficulty with this anti-arrhythmic agent classification. I hope one day I master this. So class 1 has 3 subdivision A, B, and C. A would be sodium channel blockers. A would be sodium channel blockers. Example, disopyramide, procainamide, and quinidine. Right? Next, uh, 1B, it is inactivating the sodium channel. This is also a sodium channel blocker, but problem is that the resting potential will be extended in case of 1A and it will be shortened in case of 1B. Example, lidocaine and mexiletine. Class 1C binds to all the sodium channels and it has a minimal effect on the resting potential. Example is flecainide and propafenone. Okay, this is 1. 2 is very easy. 2 is beta blocker. All the beta blockers will come to do, like esmolol, metoprolol, propranolol. 3 is a potassium channel blocker. 3 is the potassium channel blocker. Example, amiodarone, dofetilide, ibutilide, sotalol. All these things come under class 3. Class 4 would be calcium channel blockers. Diltiazem, verapamil would be class 4. Class 5 would be this miscellaneous ones like adenosine, digoxin. So this is how the antiarrhythmic agent is there. Every time I read it, I forgot. I remember in my final anesthesia exam, they asked me amiodarone. I remember it is a potassium channel blocker and I forgot what is the class arrhythmic. But thankfully, that was a model exam. So I escaped. He was like, go first read the antiarrhythmic class and then come for the next exam. So it is very volatile, but I don't know. Somehow we have to memorize it. Then coming to the types of arrhythmia and its particular treatment. How do you treat AF? Atrial fibrillation as well as atrial flutter. How do you treat it? Anyone? How do you treat? See, all these things, if the patient is hemodynamically stable, then you give them drugs like beta blockers. Whereas when the patient is hemodynamically unstable, any arrhythmia on this case, arrhythmia, any arrhythmia, if the patient is hemodynamically stable, that means you are able to record the BP in the patient and the patient is conscious oriented, you go for conservative management. Whereas if the patient is hemodynamically unstable, you go for cardio version. Using around, if it depends on monophasic or diphasic shock you give. If it's monophasic, you go for 200 to 300 joules. If it's biphasic, you go for 150 to 200 joules and you cardio with the patient. Right? This is the basics everywhere. If you ask me specifically, if it's a paroxysmal supraventricular tachycardia, if it's the drug, I'm speaking only about the stable, hemodynamically stable arrhythmias here. If it is supraventricular tachycardia, my first choice would be adenosine. Then what is the second choice? The second choice could be verapamil. Right? This is how you give the drug. Then, this is the drug which you give. Then what is that? Ventricular fibrillation. The first drug I would give could be lignocaine. The second option, or even the first option, could be brutilium also. Brutilium. Brutilium. Then WPW syndrome, you treat it with flecainamide. It's not flecainamide, it's flecainide. Flecainide. Torsades de pointus. Because you treat it with magnesium. Right? So these are the cardiac drugs, that is anti-arrhythmic agents that you have to know. The other things which you have to know in case of this cardiac is the diuretics. It has got kidney and this CVS role. We'll discuss here itself. High efficacy loop diuretics. High efficacy loop diuretics. Example, loop diuretics. Example, furosemide. Then what else? What else? Tell me. Any other examples of loop diuretics? Torsemide. Right? Loop diuretics basically acts at the level of the loop of Henle. That's why it is called as the loop diuretic. Then medium efficacies. Includes the thiazides. Example of thiazides, hydrochlorothiazide. Then low efficacy or a weak diuretics would be carbonic anhydrase inhibitors. Like acetazolamide. Then potassium sparing diuretics. Example, potassium sparing diuretic example. Tell me, potassium sparing diuretic
Spironolactone.
example? Yes, spironolactone. Then what do you call it as osmotic diuresis? Osmotic diuretics. Any one example of osmotic diuresis?
Mannitol.
Family.
Exactly, mannitol. Mannitol, glycerol, isosorbide. We forgot to discuss about the channel which is blocked by this loop diuretics. What is the channel blocked by loop diuretics? Sodium, potassium, chloride channel is blocked. Whereas thiazide, it blocks the sodium chloride channel in the distal convoluted tubules. Right? Carbonic anhydrase, of course, the enzymes carbonic anhydrase. Potassium zerin diuretics, this is almost at the level, at the junction between distal convoluted tubule and the collecting duct. I will say distal convoluted tubule. And it blocks the sodium potassium H plus channel. Osmotic diuretics, how will it act? Osmotic diuretics, how do you think it will act? It will cause hyperosmolarity of the blood. When the blood becomes hyperosmolar, what will happen? It will absorb all the edema, the fluid, interstitial fluid in the body, and bring it inside the intravascular space, thereby increasing the intravascular volume. So when the intravascular volume is increased, when the GFR is good for the patient, obviously the kidneys will wash out the the extra interstitial fluid that was absorbed inside the blood circulation. So this is how that acts. The mannitol acts. Then coming to few antihypertensives and their side effects. Before that, what is the normal BP for a patient? Normal BP is around 120/80, right? When the systolic BP is more than 129, then when the diastolic is normal, you call it as an diastolic. Even if it is around 80, you call it as elevated BP. When the systolic BP goes to 130 to 139 and diastolic BP goes to 80 to 89, it is a stage 1 of hypertension, systemic hypertension. When the systolic BP goes to 140 and diastolic BP to 90, we call it as stage 2 of hypertension. When it goes more than 180, systolic BP goes more than 180 and diastolic BP goes more than 120, we call it as hypertensive crisis. We call it as hypertensive crisis. So of course, you treat the antihypertensives, right? You give antihypertensives for the patient. If the patient is having angina, treatment of hypertension in a patient with angina, what is the drug preferred? You prefer calcium channel blockers and beta blockers. If the patient is a benign prostatic hypertrophy along with hypertension, you treat with alpha blockers. If the patient is diabetic and increased lipids, hyperlipidemia, in this case, you treat the patient with AC inhibitors or angiotensin receptor blockers or calcium channel blockers and alpha blockers. But the initial choice would be AC inhibitors and angiotensin receptor blockers. If this patient is having a low renin hypertension, then you treat the patient with diuretics and then calcium channel blockers. If it's a high renin hypertension, you treat it with AC inhibitors ARBs, and beta blockers. If the patient has asthma and if you want to treat the patient, you basically give diuretics for the patient along with calcium channel blockers. Right? If the patient is having hypertension and thyrotoxicosis, you give beta blockers for the patient. Then if the patient is pregnant, what is the choice of drug? Pregnancy hypertension, the choice of drug would be labetalol, cardioselective beta blocker, labetalol. This will be the first option. Second thing, I can go for a methyl dopaclonidine. Depending on the situation, I'll choose the drug. Then these antihypertensive drugs has a very common side effects like diuretics. What is the side effect of diuretics? Electrolyte imbalance. They try to wash out the sodium and there are high chances of hyponatremia to happen in these patients. How about beta blockers? Beta blockers have a possibility of causing fatigue and depression. Alpha blockers, they have a chance of producing hypotension, dizziness, right? Then calcium channel blockers, they cause edema of foot. And angiotensin receptor blockers, they have increased chance of having increase in the potassium in the body. Then AC inhibitors, they have what do they produce? AC inhibitors, very important question. They cause dry cough, angioedema, and even this causes increase in the potassium in the body. Then when you treat the patient with alpha agonist, the patient can have dry mouth, drowsiness, and rebound hypertension. Okay, these are the things that can happen as a side effect for the antihypertensive drugs.
Yes, ma'am.
Okay, good. I hope my screen is also visible.
Yes, ma'am.
Is my okay, good. So we discussed about the diuretics previously itself, right? So I'll add a few points here. In diuretics, these carbonic anhydrase inhibitors, they basically act at the proximal convoluted tubule, and this acetazolamide is used in the treatment of many, and few includes Meniere's disease, mountain sickness. The prominent side effect of this drug is it causes acidosis. Next, the hydrochlorothiazide, it acts at the distal converting tubule. It is used in the treatment of hypocalcemia and nephrolithiasis. And the prominent side effect of this drug could be hypokalemia and hyperuricemia. Like this hypocalcemia, it is not like you don't have to give calcium, you just have to give hypocalcemia, give this diuretic. It is not like that. In a volume overloaded state, you can give this diuretics whenever there is a coincidental hypocalcemia for the patient. You have to take it in that sense. Then this loop diuretics, it is used in the treatment of hypercalcemia. It will help to wash out the calcium from the body. The problem with loop diuretics is the side effect, that is the ototoxicity. Ototoxicity and hypokalemia. Ototoxicity and hypokalemia. This potassium sparing diuretics, of course, the side effect will be hyperkalemia. Hyperkalemia. Then this osmotic diuresis. What are the areas where you use it? It is used in the cases of increased ICP, and it is also used in lithium toxicity. And the side effect of this drug could be hypovolemia, and thereby causing hypotension. Okay, hypovolemia, thereby causing hypotension. So that's not much in the renal drugs. Diuretics are the ones which are involved in the concern for us in the renal. Next, going to CNS. The CNS, the thing which you have to know is the anti-epileptic agents. What are the anti-epileptic agents that you know of?
Valproate.
Yes, valproate,
Phenytoin.
sodium. Phenytoin. Phenytoin is the first drug. Phenytoin is the prototype drug. How does it act? It inhibits the sodium channels, and it is used in the treatment of GTCS, partial seizures. Then that's all. Then the other one is carbamazepine. Carbamazepine. It is also a sodium channel blocker. It is used in the treatment of partial seizures. What is the problem in which the carbamazepine is a drug of choice?
Trigeminal
It is exactly trigeminal neuralgia and post-herpetic neuralgia. Post-herpetic neuralgia, benign bipolar disorders. Even in the bipolar disorders, carbamazepine may be used, but the main drug of choice would be this trigeminal neuralgia. Then we spoke about valproate, sodium valproate. Sodium valproate, it is a microsomal enzyme inhibitor. It is a microsomal enzyme inhibitor. It is used in the treatment of GTCS, partial seizures, then tonic-clonic seizures, then Lennox-Gastaut syndrome, then infantile spasm, petit-mal seizures, okay, migraine prophylaxis. All these things could be a possibility. Then, what is the treatment of choice of absence seizures? What is the treatment of choice of exactly etosuximide? Etosuximide. It is basically, it inhibits the T-type calcium channels, and it is the drug of choice for absence seizures in children less than 2 years of age. Right? The other things which you can use is barbiturates, thiopenton can be used. It is a GABA mimetic action. GABA is basically gamma aminobutyric acid, is a inhibitory neurotransmitter in the body, and it is used in the treatment of GTCS, which is not controlled by anything, and also partial seizures. Then benzodiazepines. Benzodiazepine has a GABA facilitatory action. It makes sure that the GABA goes and binds, and it is used in the treatment of acute episode of seizures. Then febrile seizures. So this is what is regarding the drugs for anti-epileptics. There are few things that you have to know regarding the side effect of this drug. One such side effect that you have to know is this phenytoin. It has got many side effects. You remember the do you know the mnemonic for this phenytoin side effect? Phenytoin, the adverse effect, you have to remember it as Thomas. First, it is teratogenic. Second thing, it causes hypertrophy of gingiva. And also it causes hirsutism, osteomalacia, megaloblastic anemia. Megaloblastic anemia. Then ataxia. Then it causes sugar, that is hyperglycemia. These are the important side effects of phenytoin that you have to know of. Then you have to know about this lithium. Lithium is a drug which is used in the psychiatric. It is an antipsychotic agent. The reason why you have to know about the lithium is because of the therapeutic level of lithium. Level of lithium has to be maintained 0.5 to 0.8 milli equivalents per liter as a prophylactics or maintenance therapy. For an acute episode of mania, you have to maintain 0.8 to 1.2 milli equivalents per liter. When it goes more than 1.5, then toxic manifestations start for the patient. And since the lithium is secreted, milk, should not be given to a. So this is how what is regarding the. Am I audible? Am I audible?
Yes, ma'am. Yes, ma'am.
Okay.
Yes, ma'am.
So these are the important CNS drugs. Then coming to few drugs in GIT that is very important for you. H2 blockers. Any example of H2 blockers? It blocks the HCl secretion in the stomach. Example, ranitidine, cimetidine, famotidine, so many are there. Right? Then antacids. Example of antacids, aluminium hydroxide. It is an antacid which is used. Proton pump inhibitors. Example, omeprazole, pantoprazole, rabeprazole, lansoprazole. Many are there. I'm just mentioning the name. This suppresses the proton pump so that HCl is not secreted in the lumen, and hence the gastritis is prevented. This antacid, it helps in neutralizing the gastric acid. Then Mucosal protectants. Example, mucosal protectant drugs. Example is supercharge. It forms a coat around the stomach so that the acid does not injure the stomach mucosa. Then prostaglandin analogs. Example is misoprostol. It inhibits the gastrin secretion. Misoprostol basically inhibits the gastrin secretion, thereby decreases the HCl. That is one point. Second thing, it increases the mucin in the stomach so that the mucous layer is maintained. So these are the anti-ulcer drugs. If you ask me another things, what are the laxative agents which is used? Laxatives that you know of. First, chemical laxative, Bisacodol. It directly stimulates the GIT nerves and it increases the peristalsis. It is rather an irritant laxative. Right? Then, mechanical laxative. Mechanical laxative is lactulose. It increases the fluid content. It absorbs, it pulls up all the fluid inside the gut so that the fetal content become more bulkier to come out. That is how lactulose acts. Then lubricants. Example, Docusate or any mineral oil. It helps in lubricating the intestinal content and throw it out. This is how laxatives act. How about antidiarrheal agents? Antidiarrheal agents, local reflex inhibitors. Local reflex inhibitors, the drug is bismuth salicylate, subsalicylate. It basically coats the lining of the GIT to soothe the irritation that happens because of the diarrhea. Whereas, excuse me, local anti-motility drug. This local anti-motility drug example is loperamide. This loperamide, it inhibits the intestinal muscle activity and it slows the peristalsis. Central acting is the ones like the opioids. It causes constipation, GIT spasm, basically. Opioids, GIT spasm, and causes constipation. So that's how they treat the diarrhea. Then the other problem that happens with this GIT is emesis, vomiting. So antiemetics that you know of, earlier used antiemetics were phenothiazines. Example, prochlorperazine, promethazine. Prochlorperazine and promethazine, it basically blocks the vomiting center at the level of medulla. And it is also used in the treatment of intractable hiccups. Then non-phenothiazines. Example drug is metoclopramide. It reduces the response of the nerve signals at the medulla level. And it also blocks the dopamine receptors. The problem with this metoclopramide is it can cause extrapyramidal symptoms. Then anticholinergics. Anticholinergic is meclizine and buclizine. It also decreases the impulse transmission at the medullary level, also at the local level. Then what else? This thing, this ondansetron, those are all serotonin receptor blockers, 5-HT3 receptor antagonist. 5-HT3 is nothing but serotonin, so 5-HT3 receptor blockers are all cetrons, ondansetron, alanositron, ramosetron, granisetron. Initially, the cetrons were all used for the vomiting induced by chemotherapy agents, but nowadays everywhere, if vomiting is there, everyone gives emicet only, ondansetron only. But the problem with this ondansetron is there are high chances of causing QT prolongation. I don't know how many of the doctors who know about QT prolongation give emicet unnecessarily. I am very much afraid of giving emicet randomly. Whenever I give medicine, I stand near the patient for a long time to find out if there is anything happens, because it's not a drug which is like, which will be like, it will not cause a problem. It is a very risky drug only. So we have to be very careful while giving medicine. So that's all regarding the anti-emetics. So this is what is regarding GAT. Then coming to respiratory. In respiratory, we have antitussives, right? What do you call antitussive? What is an antitussive? What is an antitussive? Come on, what is an antitussive? Am I audible?
Yes, ma'am.
Am I audible? Okay, antitussive means cough. It is an anti-cough agent. Okay, dexamethasone, which is there in almost all our cough syrup. This dexamethasone is an NMDA, N-methyl D-aspartate receptor antagonist. Okay, and that's how it causes an antitussive action. The adverse effect of this drug is mainly nausea, vomiting, and drowsiness. Vomiting, drowsiness, and sometimes blurred vision. Okay, then decongestants, phenylephrine. I already spoke about phenylephrine, right? That is a decongestant. The other one is the antihistamines. Antihistamines means it includes the diphenhydramine. 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 Okay, then levocetirizine, levocetirizine, promethazine, hexofenadine, Allegra, hexofenadine. All these things are antitussives. What is their role? They rather, one thing, they will decrease the histamine release from the mast cells in the respiratory tract, thereby causing a decrease in the inflammatory reaction. The problem with these drugs is it can cause sedation. It is a tranquilizer. We try to misuse it. Right? Then the other thing which you have to know is the expectorant. What is an expectorant? It basically brings out the extra secretions that you have in your body. Directly acting agent includes guanfacine. I'm not very happy with spelling. Guaifenesin. Guaifenesin. Sodium citrate. You can remember it as guaifenesin. That is enough. Right? And the indirectly acting ones, include the IP pack, sodium ammonium salts. Both these things, it decreases the thickness of the expectorant or the secretion. Thereby, it helps in coming out of the content. The problem with this expectorant, it causes gastric irritation. Right? Then the other things which you have to know is the mucolytics. This mucolytic example is the N-acetylcysteine. This N-acetylcysteine decreases the viscosity of the mucus, thereby breaking the, once it breaks down, it is easy for it to come out. Then bromhexane. It is also used in thinning and fragmentation of the mucopolysaccharide fibers in the sputum. Fragmentation of mucopolysaccharides in the sputum, so that it comes out very easily. Once it is detached from the mucous membrane, it comes out very easily. The problem is with this bromhexane is because of this, there are high chances of rhinorrhea to happen. There are high chances of rhinorrhea to happen. Then coming to the, I think bronchodilators, we already saw the bronchodilators, short-acting and long-acting. Short-acting salbutamol, long-acting as salmeterol. Other short-acting agents will be this terbutaline, and long-acting will be formoterol. All these things causes bronchodilation. The other anticholinergic agent following bronchodilation, one anticholinergics cause bronchodilation agent, hypertrophium bromide. Hypertrophium bromide, it is an anticholinergic causing this bronchodilation. It acts at the M3 receptors, and also it decreases or inhibits the mucus secretion. The problem with this side effect of this drug is urinary retention. And all those dry mouth, constipation, headache, all the anticholinergic action will come. Okay. Then a short-acting bronchodiagonist, beta agonist, long-acting beta agonist, we already discussed. However, the problem, the side effect of both these agonists would be tremors, vascular headache, then fluctuations in BP. The other bronchodilators which we use are theophylline. These are all methylxanthine. Actually, theophylline is a drug name. The broad group is methylxanthine. This methylxanthine, it causes tachycardia, and hence it is not used more in the present scenario. How do this methylxanthine act? It causes the PDE inhibition, phosphodiesterase inhibition, thereby leading to the accumulation of cyclic AMP and cyclic GMP, thereby preventing the airway inflammation and causing bronchodilation. This is how this methylxanthines will act. Then the other respiratory drug could be anti-inflammatory agents like glucocorticoids. Right? This glucocorticoids, it can be given either inhaled, or it can be given oral, or it can be given in the injectable form also. How will this inflammatory glucocorticoids act? It decreases the synthesis of inflammatory mediators. It decreases the synthesis of inflammatory mediators, thereby reducing the bronchial hyperactivity. Thereby reducing the bronchial hyperactivity, and further proceed. The other anti-inflammatory agents that is used is the leukotriene antagonists. Leuko. L-E-U. Leukotriene antagonist. The leukotriene antagonist, example, montelukast, zafarlukast. These drugs basically prevent the bronchoconstriction from happening. And the main side effect of these drugs are headache, nausea, rashes. Okay. Then the other anti-inflammatory that is used is the mast cell stabilizers. Mast cell stabilizers. This mast cell stabilizers, it is used for, the drug used is the sodium bromelain. It works at a cellular level and decreases the histamine release, thereby preventing the preventing the inflammatory reaction from happening. Possible side effect could be some hypersensitivity, headache, and throat irritation can happen because of this sodium bromelain. I can say that it is a mast cell stabilizer. It stabilizes the mast cell from not releasing the histamines, which is causing the hyperreactivity reaction inside the respiratory tract. Then coming to the immunosuppressants, which is used for autoimmune diseases. First immunosuppressants that you have to know, the mechanism is all too big. The MCQ that can be asked is the side effect of these immunosuppressants. First is cyclosporin. What is the side effect of cyclosporin? It causes gingival hyperplasia. What is the other drug which we discussed today that causes gingival hyperplasia? Come on.
Phenytoin.
Exactly. Tacrolimus. It causes hyperglycemia. Even phenytoin also causes hyperglycemia. Then mycophenolate mofetil. It causes neutrophils, decrease in neutrophils, neutropenia. Then thrombocytopenia. These causes impaired wound healing. And extremity edema. Extremity edema. All these things were caused by mycophenolate mofetil. Then sirolimus. Sirolimus. It causes leukopenia, thrombocytopenia, and GI upset. Then corticosteroids can also be used as an immunosuppressant. Corticosteroid, it causes hyperglycemia, cataract, myopathy, osteoporosis. Then azathioprine. Azathioprine, there are high chances of anemia to happen with azathioprine, leukopenia, thrombocytopenia, everything will reduce along with GI upset. These are the possible side effects that happens because of the immunosuppressor drugs. Then coming to the anti-diabetic drugs, which is the most commonly used anti-diabetic drug. What is the most commonly used anti-diabetic drug? Come on. oral hypoglycemic agents. Most commonly used is biguanides, right? Example of biguanide, metformin. Almost every patient is having metformin nowadays, right? Metformin, biguanide, how does it act? It decreases the glucose production in the liver. What is the side effect of metformin? It causes lactic
Weight loss.
acidosis. Yeah, weight loss, I will not say a side effect. It is not an adverse effect. It is a good thing, right? A diabetic patient losing weight is a good thing. I'm asking an adverse effect. Of course, it causes weight loss. Adverse effect, diarrhea. Loose foods will be there for this patient. Diarrhea, lactic acidosis, sometimes nausea, and metallic taste. These are the adverse effects that happens with biguanides, that is the metformin. Then the second most commonly used drug is the sulfonylurea. Example of drugs in sulfonylurea, glimepiride, glipizide, glyburide, tolzamide, tolbutamide. So these drugs, how will they act? It acts at the level of pancreas to increase the insulin. Right? The problem with this sulfonylurea drug is it causes hypoglycemia. Right? Then the next commonly used is the alpha glucosidase inhibitors. As the name suggests, it is inhibiting the alpha glucosidase that is present in the diet which we have. So this drug has to be had along with the diet, along with the food. Example, ecarbos, voglibos. These drugs, what will you do? What will this do? It slows the absorption of sugar from gut. The problem with this drug, it will cause bloating and flatulence. It will cause bloating and flatulence. The other drug which is more common nowadays is the thiazolidinons. Thiazolidinons. Example is pioglitazone and rosiglitazone. How will this drug act? This drug increases the insulin sensitivity of the cells. Okay, they make the cell response to the insulin, so increases the insulin sensitivity and also decreases the glucose production in the liver. The problem with this thiazolidinons is it causes edema, especially pioglitazone. It causes edema. Then it increases the chances of fractures to happen, and also it increases the chance or risk of CA bladder. This is very, very important question. They will ask you in this exam. Pioglitazone increases the chances of CA bladder, whereas rosiglitazone increases the chances of MI. Okay, so this could be the possible MCQ you can have in your examination. Then dipeptidyl peptidase 4 inhibitors. Dipeptidyl peptidase 4 inhibitors. Example, linagliptin, linagliptin, sitagliptin, saxagliptin, vidagliptin, so many gliptins are there. Okay, all these things increases the incretins, thereby the blood sugar is reduced. Okay, the problem with this drug is it can cause pancreatitis, pharyngitis, and headache. Then the other drug which can be which are under use now is the glucagon-like peptides. Glucagon-like peptides 1 agonist. Okay. Then drug name includes exenatide, liraglutide. Okay. All these things will cause, it also increases the incretin so that blood sugar is reduced, and the problem with this drug is it causes GI upset. The one more drug which is very famous now and you have to be very careful with this drug is SGLT2 inhibitors. Okay. This drug example is canagliflozin, dapagliflozin, then empagliflozin. These drugs try to cause glucosuria. It increases the glucosuria. It tries to eliminate the glucose in the sugar. The problem with this drug is there are high chances of euglycemic diabetic ketosis to happen in the patients having this drug. Euglycemic diabetic ketoacidosis to happen in the patients who have this SGLT2 inhibitors. And that's why whenever this for anesthesia, whenever patient comes with this SGLT2 inhibitors, we make sure that the patient is not in the ketosis before we proceed for surgery. Then if there is an increased chances of urinary tract and genital tract infection, and there are high chances of dehydration to happen because of this drug. Okay. Is there anything remaining? Meglitides are remaining. Meglitides. Meglitides. This drug example, metiglenide and rapaglenide. This helps in increasing the insulin by stimulating the pancreas. Of course, the adverse effect of this drug would be hypoglycemia. Then D-phenylalanine derivative. Example is natiglenide. This also acts at the pancreatic level to increase the insulin, and similarly it is also can cause hypoglycemia. So these are the most commonly used anti-diabetic drugs. Then coming to the last chapter, I think.
Yes, ma'am.
From where did you stop hearing me?
From antimicrobials, ma'am.
From the starting of antimicrobials. Yeah.
You started to write a title, ma'am. After that, the screen went freeze.
Oh my God! I finished that entire chapter itself. You guys could have told me earlier itself.
Ma'am, I messaged you, ma'am. I messaged you and.
Where did you message me in Zoom platform?
I mean, in the Zoom, ma'am. In the Zoom.
I didn't see the message at all. I finished the entire chapter. Anyway, it's okay. So I was just thinking about this antimicrobials, which has this cell wall inhibitors, where penicillin, cephalosporin, carbapenems, Vancomycin and monobactams, all these things are cell wall inhibitors. The one MCQ which can come for this is vancomycin, where the toxicity of vancomycin could be Redman syndrome, ototoxicity, nephrotoxicity, and thrombophlebitis. This Redman syndrome is the most important MCQ. Then the protein synthesis inhibitors, the main drug is the aminoglycosides. The aminoglycosides problem is that it is highly nephrotoxic, autotoxic, and it has got a high teratogenic potential. Then the tetracyclines also come under protein synthesis inhibitors. Among the protein synthesis, this chloramphenicol is not, it is banned, it is no more used. It's because of the gray baby syndrome, it is not used. The macrolides, like the azithromycin, all those things come under protein synthesis inhibitors. Then the folic acid synthesis inhibitors, these drugs act at the nuclear level. The example of drug is trimethoprim. The trimethoprim is almost active against all the microorganisms. The problem with this drug on long-term use, it causes megaloblastic anemia, leukopenia, and granulocytopenia. Usually, the sulfonamides will be given along with this trimethoprim, but the problem is that there are high chances of hemolysis to happen in the G6PD deficient patient in this. Hemolysis to happen in G6PD deficient patient whenever they are given sulfonamides. And also, pernicious chances is more for the infants who is exposed to sulfonamides. Then about para-aminosalicylic acid, this is the problem with this drug is, though it is a good antimicrobial property, it has a high chances of forming, hypothyroidism to happen, along with chances of hepatitis and electrolyte abnormalities. Then coming to the topoisomerase inhibitor, which is the fluoroquinolone. The problem, side effect, apart from the regular side effect like dizziness, rashes, and everything, there are high chances of tendon rupture to happen in this topoisomerase inhibitors. DNA replication inhibitor, example is metronidazole. This is a drug which is used most commonly for GAT cases and anaerobic cases. You use this DNA replication inhibitor. RNA replication inhibitor is rifampin. DNA dependent RNA inhibitor is rifampicin. Then I was asking you about this mycolic acid inhibitors. Where will you see mycolic acid? In which organism will you see mycolic acid?
Bacterial cell wall.
Which bacteria? Which bacteria? Be specific. You
TB,
see it
ma'am.
in mycobacteria, exactly, mycobacteria. In TB and leprosy only, you see this mycolic acid. So the drugs for this includes the ETP agents. Isoniazide. This isoniazide is very important, and the main concerns are the side effects. Isoniazide, side effect of isoniazide is hepatotoxicity. Hepatotoxicity and peripheral neuropathy. Then other pyrazinamide. Pyrazinamide, it causes hepatotoxicity and gout. Then ethambutol. Ethambutol, it causes, side effect includes retrobulbar neuritis and gout. Then ethinamide. The problem with this drug is it causes hypothyroidism and hepatotoxicity. All right. So this is how the antimicrobial agents work. Then you have to know, I hope you have a list of antimicrobials which is used against the particular organisms, like drug of choice for this particular microorganisms. If you have that list, you might have studied detail in the microbiology list. If not, I think Robin will be having it asked. He will give you the paper. So read from that drug of choice. Next, coming to the last chapter, that is autocoids. Autocoils are basically like if it's an amine autocoid, it is histamine and 5-hydroxytryptamine. That is the serotonin. Then peptide autocoids includes the bradykinin, thylidin, angiotensin. Lipid-derived autocoids, it includes the prostaglandins, leukotrienes, and platelet activating factors. These are the autocoids. Among this, the most concern for us will be the histamines. And hence we use the histamine antagonist. We spoke about the histamine agonist and antagonist. Mostly histamine agonist is not used anywhere. It just mimics a acute allergic reaction, so it is not used in many of the situations. Only the antagonist is used. That H2 blockers, ranitidine, cimetidine, all these things decreases the gastric acid secretion. So that should be fine for you. Then you have to know about the serotonin receptors. We spoke about this 5-HT3 receptors alone. The other receptor which can come in your question is this 5-HT serotonin receptor. We spoke about 5-HT3. The other receptor which you can have is 5-HT2C receptor. It is involved in CSF production and neuronal excitation. And this drug's agonist, this receptor agonist is vabicoserine, and antagonist is methylsergide. Okay, this could be asked as a question. Methylsergide is an antagonist of which receptor, or antagonist of 5-HT2C is what? You can ask. Then another one which you can ask is 5-HT1A receptor, which is also involved in neuronal inhibition. It's involved in neuronal inhibition. The agonist would be buspirone and antagonist would be the ergotamine. Okay, so there are many. I think this should be fine for you. Let's not go too much deep. Let me ask you a few questions in antimicrobials, the drug of choice, which I was telling you. Drug of choice, you guys should be active in those, okay? What is the drug of choice for Neisseria gonorrhea? First, what is the drug of choice for Neisseria gonorrhea? Exactly, ceftriaxone. Along with this, you have to add either azithromycin or doxycycline. Okay. Neisseria meningitis, drug of choice is penicillin groups. Then, how about MRSA, methicillin resistant Staphylococcus aureus? What is the drug of choice for methicillin resistant? Exactly, vancomycin. What is the drug of choice for vancomycin resistant Staph aureus? Linezolid. Okay. Linezolid, then dalfopristin, quinopristin, right? Then drug of choice for Acinetobacter, pinums, carbopinums, imipenem or meropenem. Then Brucella, drug of choice for Brucella, doxycycline and rifampin. Rifampin. Then drug of choice for any anaerobic organism. What is the drug of choice? First drug you think of. The cephalosporin group that is used in anaerobic eradication is ceftazidime. Okay, ceftazidime is a cephalosporin group that is used in eradicating the anaerobes. Then important things like Formibacterium diphtheria, drug of choice for diphtheria. It is the macrolides. You have to read the drug of choices. The big list is there. You have to read that. What is the drug of choice for Malassezia furfur? What is the drug of choice for Malassezia furfur? Come on. First of all, what is it? Bacteria, virus, or fungus? Hmm? Is it? Am I audible? Yes, it is a fungus, so you have to give an antifungal, right? What is the drug of choice? It is ketoconazole. It is the ketoconazole. What is the drug of choice for chromoblastomycosis? It is itraconazole. Right? Drug of choice for pneumocystis carinii. Drug of choice for pneumocystis carinii is cotrimoxazole. It is cotrimoxazole. Then what is the drug of choice for influenza? Influenza means what drug will you give? You give oseltamivir. Oseltamivir. Okay. Then you have to read the antiretroviral drugs. You read the regimens which is there in the updated one. Then what is the drug of choice for this varicella zoster virus? You can go for any acyclovir. Then herpes simplex virus also you give this acyclovir. Herpes simplex virus resistant to acyclovir, what will you give? You have to go for phoscornet. You have to go for phoscornet. Okay. So then what is the drug of choice for this trypanosoma brucei? That is the African sleeping sickness, right? What is the drug of choice? Trypanosoma brucei African sleeping sickness. This generally they say pentamide. Okay, this is for non CNS informant. There are many like different African sleeping sicknesses there. One is the East African sleeping sickness. The other one is the West African sleeping sickness. In West African sleeping sickness, if it is non-CNS involvement, then the drug of choice is pentamidine. Okay, if there is a CNS involvement, you have to treat with eflornithine and nifurtimox. Okay, if it is East African sleeping sickness, you have, if it is a non-CNS involvement, you have to give Sumarin. If it is a CNS involvement, it is melarsoprol. Okay. Then, if you think of this difortimox, what else is what else is treated with difortimox? Difortimox, not the difortimox. Nifortimox. What else is used in the treatment of nifortimox? Am I audible?
Yes.
Okay, nifortimox. You know, it's Chagas disease. Chagas disease, right? Chagas disease is caused by Trypanosoma cruzi. Causes this Chagas disease. So this is basically treated with nifortimox along with benzimidazole. Nifortimox along with benzimidazole. And what is the treatment of plan for treatment of choice for Toxoplasma gondii? What is the treatment of choice for Toxoplasma gondii? Spiramycin. Come on, these are all important MCQs. Okay, there is a big list. Ask this DMA people, they will give you the list. You make sure that you read that list properly before you go for your examination. What is the treatment of choice for Enterobius vermicularis? It is albendazole. Albendazole is used in the treatment of Enterobius vermicularis. Okay, so this is what is regarding the drug of choice. There are many drug of choice. You have to read it. Make sure that you get the list from them, and you read each and every one. Maybe I can do something. You get the list from them today itself, so that tomorrow when I ask you questions, I will concentrate more on the drug of choices so that you can answer me properly. You have to know about the antidotes also, poisons and antidotes. For paracetamol, what is the antidote? It is N-acetylcysteine. For atropine, antidote, it is the physostigmine, or I can say pyridostigmine. We nowadays use pyridostigmine only. Then organophosphates, antidote is atropine. Benzodiazepam, antidote is flumazenil. Carbamates, antidote is atropine. Right? For OPC poisoning, you also give this what is that? Treatment. This atropine is just the direct antidote. Okay. But for treatment, antidote is atropine, but for treatment, you use pralidoxine. For atropine, it is physostigmine. Okay, I wrote it wrong. physostigmine only. Then what else? Cyanide poisoning, nucleated antidote for cyanide poisoning is sodium nitrite. Then antidote for isoniazide is pyridoxine. Okay, then stringin, the spinal poison, strychnine. The antidote is diazepam. Okay. There are many. I have mentioned only few. Antidote of methanol is ethanol. Okay. So I have mentioned few. You make sure you get the list from them and you read. So I don't know whether we will have a session tomorrow. Ideally, we were supposed to cover medicine in the next session. I will update you by tomorrow morning whether we are having tomorrow's class or not. If not tomorrow, definitely there will be a class day after tomorrow. I'll try to make sure to take tomorrow itself. If not, we'll go have it day after tomorrow. I'll update you tomorrow morning around 10 o'clock whether we have class or not. Okay.